and we need to hold House Bill 1298.
Mr. Chair, I'd also like to hold
that.
House Bill 867.
We will hold that. Thank you.
Thank you.
All right, I wish to call this meeting of the Health Occupation Subcommittee to order. We will begin with House Bill 1004, Public Health, Alzheimer's disease and related dementias, information on prevalence and treatment. Delegate Martinez. Council. There are
This bill expands the information that the Maryland Department of Health, in partnership with specified entities, must incorporate into relevant public health outreach programs to include information for healthcare providers on treatments approved by the FDA for Alzheimer's disease and related dementias, and to increase understanding and awareness of early treatment of Alzheimer's disease and related dementias. The amendments that have been distributed require the outreach information to educate healthcare providers on treatment, use, and outcomes, and to increase public understanding on the treatments approved by FDA for Alzheimer's disease and related dementias, and relevant information, including information related to treatment outcomes based on biological sex. And the amendments also require that in the information that MDH will collect, that they will collect data on the hospitalization rate of Alzheimer's disease and related dementias, disaggregated based on co-occurrence of Down syndrome and type of dementia. And these amendments were approved in the Senate Finance Committee, I believe, last night.
Okay, sponsor.
Thank you, Mr. Chair. And thank you, Lisa. Yeah, the amendments are supported by Megan and the association. I checked in with them last night when I heard the Senate was going to be moving forward with these amendments. So I just thank everybody on their work on this and ask for a favorable report, because these amendments with the process.
So a favorable report on the amendments would conform the bill to the action taken on the bill last night by
Yes.
Senate Finance. Is that correct?
Correct.
Okay.
So move the amendments, Mr. Chair.
So
Second.
moved. The amendments are moved and seconded. Do I hear a second?
Yes, second.
And seconded. Is there discussion on the bill as amended? If not, all those in favor of the bill as amended, say aye.
Aye.
All those opposed? It is unanimous. Is there a motion on the bill as amended?
Move the bill as amended.
moved.
Been moved and seconded. Is there any discussion on the bill as amended? All right, all those in favor say aye.
Aye.
Anyone opposed? There is no one opposed. Okay, the bill moves forward as amended and as conformed to the Senate action of Senate Finance Committee action of last night. Okay, looking for next, that is Lisa's. House Bill 1409, since that's not a likely hold. House Bill 1409, Health, Medical Care Facilities, Electronic Monitoring Devices.
As introduced, this bill required a medical care facility to allow a resident or the legal representative of a resident to monitor the resident through the use of an electronic monitoring device. There were amendments that have been distributed, and with those amendments, they codify VERA's law, and they require the Maryland Department of Health to develop guidelines for an assisted living program that elects to use electronic monitoring with the consent of a resident or the legal representative of the resident. The amendments also provide that it's the General Assembly's intent for MDH to apply VERA's law, which currently applies to nursing homes, to assisted living programs, and to then review changes in technology since VERA's law was originally released, which was in December of 2003, and to update the guidelines to reflect changes in technology and the addition of assisted living programs as necessary.
So that's, in summary, what this bill would do is extend VERA's laws from nursing homes update and extend Vera's laws to assisted living facilities.
Correct.
Correct, okay. Fine, those are the amendments. Delegate Warman, do you have any comments? Are you present?
Yes, I'm here, Mr. Chair, and thank you so much for the subcommittee's time. Lisa said it right. The amendments do that expansion of Vera's law, and these amendments were in coordination with Lifespan and Dana Kaufman, and she's okay with the amendment.
I see you nodding. You're always present, Dana Kaufman, honorary member.
Right.
Okay. Is there a motion to adopt the amendments?
Motion on the amendments.
Second.
Moved and seconded. All in favor, say aye.
Aye.
Aye. Anyone opposed? No one is opposed. Bill as amended, is there a motion? Is there a motion?
Move the bill as amended. Mr. Chair.
Second.
Thank you, Madam Vice Chair. Moved and seconded to bill as amended. All those in favor, say aye.
Aye.
Is anyone opposed? It is unanimous. All righty. Next and final bill that is Lisa Simpson's would be the practice of audiology, but I believe that's being held.
Yes,
So Lisa, do you have any more bills?
that's all I have. Lindsay said she was almost done. Let me check in with her.
Okay.
She is still finishing up. She'll be with us in a few minutes.
Okay. Just so those who've joined since we began, we have taken action on House Bill 1004 and 1409. We are holding 1298 and 867. The subcommittee, no doubt, will be meeting again before the week is out, before we cross over.
Were you waiting for me?
Yes, we were.
All right.
We know you were working, so no problem. Are you ready?
Yes.
Okay, fine. We'll begin then with House Bill 776, Maryland Medical Practice Act and Maryland Physician Assistance Act, revisions, Delegate Pena-Melnick.
This bill alters, clarifies, and makes consistent provisions of law regarding physicians, physician assistants, and allied health professions that are regulated by the Board of Physicians. Among other actions, the bill alters disciplinary grounds and the disciplinary process, licensure requirements, board duties, specified notification requirements, and provisions governing the allied health professional advisory committees. The bill increases existing civil penalties and establishes new administrative penalties for specified violations and repeals obsolete and redundant language and makes clarifying and conforming changes. If you all hopefully were able to get the amendments, they were large, it was hard to send them out. The amendments define the term employer and then applies that term in various places in the bill so that there are references to just employer rather than hospital-related institution, alternative healthcare system, or an employer. Relatedly, the amendments repeal the definition of alternative health system under the PA title. The amendments reduce under the bill from $25,000 to $15,000 the amount of administrative penalties the board may impose for certain violations, requires a licensee to notify the board of a change in name or address within 30 days after the change. Under current law, that's 60 days, and originally the bill proposed 10 days for this. Again, that change is made throughout the bill. The amendments correct a typo in the physician's compact, alters the grounds for discipline by the board for patterns of excessively or medically unnecessary procedures or treatment and willfully hindering board investigations. This applies to physicians, genetic counselors, and PAs throughout the bill. And then the next section that I'm going to describe it with regard to physicians, but this is also made throughout the bill for the other allied health professions. Requires reporting of disciplinary actions against physicians by employers only, rather than again to hospitals, related institutions, and alternative health systems, and specifies the circumstances for which a report must be submitted. Alters language surrounding exceptions to the report requirements relating to physicians enrolled in a substance use disorder treatment program. Strikes from the bill language regarding notice from physicians, employers, and treatment programs regarding entering a treatment program and compliance with the treatment program, and instead requires the employer to notify the board if the employer knows a licensed physician is non-compliant with a substance use disorder treatment program. Specifies that a report made relating to a treatment program is not subject to inspection under the PIA. Allows a civil penalty for knowingly failing to report. Allows a civil penalty of up to $10,000 per incident for a report that is made by an employer in bad faith, and increases from $5,000 to $10,000 a civil penalty created in the bill for employing an individual to practice medicine without a license. So again, that was all with regard to physicians and the practice of medicine. Those changes are also made with regard to the licensed respiratory care practitioners, the nuclear medicine technologists, radiation therapists, radiographers, and radiologist assistants, the polysomnographic technologists, the athletic trainers, the perfusionists, the naturopathic doctors, the genetic counselors, and the physician assistants. Finally, the amendments authorize rather than require the various advisory committees to provide recommendations and advice to the board.
Okay. Are there any questions after that lengthy description? Lengthy, or should I say
I
lengthy?
did a good job of
summary?
making it short.
Is there a motion?
Mr.
If
Chair,
somebody wished to offer the amendment?
I will move the amendments, Mr. Chair, but then I have a question.
Certainly.
Second.
And there is a second question
Yeah.
from the vice chair.
And these amendments, everyone's on board with?
This is Madeline Del Greco. I'm a health policy analyst with the board. I do believe that we're in agreement with the amendments, but I did want to mention that we spoke with Jane very recently, about 10 minutes ago, about potentially adding some additional language to that last section that we spoke about the mandated reporting, about the board may extend the reporting time under the subsection for good cause shown. So I did send an email right before this to Lindsay, but I just wanted to make that known here in the subcommittee.
Lindsay, have you received that note, that email? And had a chance to look at it and analyze it?
I have received an email. I have not opened it.
Okay, understood. Well, we're
Jane?
meeting again, so if not today, we will be meeting again in time for the Monday deadline. So I think we should hold the bill and have the amendments reviewed.
Oh.
So we will hold the bill.
Jane's got her hand up.
Whose hand is up?
Jane from MHA.
Jane, go ahead.
Hi, thank you so much, Chair Rosenberg and Vice Chair Colson for the deference and for the Board of Physicians. And I apologize for the late or last minute request. The amendment we're proposing is existing statute that I think was removed from the bill. So the amendment would just put back in existing statute, or not remove it, I guess, to give the flexibility to request an extension of the time. I think law requires 10 days. And so with good cause, the board is open to allowing longer if the hospital needs more time to investigate. Thank you.
Well, we still have time, so I think I want to put the hold and bring it up at our next meeting.
Okay.
Okay. House Bill 838, Health Occupation License Direct Entry Midwives.
Mr.
Provision.
Chair,
Yes,
could I recommend that we do 1199 first, since I think the discussion might be shorter, and
Okay.
hold 838 till the last bill?
fine. House Bill 1199, Physicians Licensing Internationally Trained Physicians.
This bill authorizes the Board of Physicians beginning October 1st, 2027 to issue a license to practice medicine to a physician licensed in a country other than the United States, its territories or possessions, Puerto Rico or Canada, who meet specified requirements. The term of the license may not exceed 3 years and the license may not be renewed. The board may revoke the license if the licensee practices outside the scope of the license, has their employment terminated, has been the subject of a disciplinary action, or is no longer eligible for the license. The bill requires the board to adopt regulations for implementation, administration, and enforcement, including minimum qualifications and application fees, conditions applicable to a licensee, and a pathway to full licensure. I don't know if Delegate Hill has joined our call. I know that she was in government ops moments ago, but she's been working with the board on some amendments, but I hadn't gotten approval from her yet to circulate them because I reworked them a little bit for her this morning. But what I did, the bill required an applicant to submit evidence acceptable to the board that the applicant had no discipline or competency issues raised during the applicant's postgraduate training. And that piece was struck. So if you're looking at the bill, it'd be page 2, lines 11 and 12, and then adds a new subsection C, authorizing the board to determine that an applicant is ineligible for licensure if the applicant has either previous disciplinary action or discipline or competency issues during the applicant's postgraduate training. And then the second piece of her proposed amendments that I think she wanted to consider separately were, again, going back to page 2, there's a requirement that the applicant has practiced medicine for at least 5 years immediately preceding the date of the application, and she wanted to change that to 5 of the 7 years immediately preceding the date of the application. So not necessarily the immediately preceding 5 years.
So what is the will of the committee? Do you think there is sufficient understanding of those additional amendments? Is there objection to moving forward?
I'd move the amendments, Mr. Chair.
So moved and seconded. Is there a second?
Second.
All those in favor of the amended bill, say aye.
Amendments.
Amendments, sorry. All those in
Aye.
favor of the amendments?
Aye.
Is there any objection to the amendments? Both sets of amendments. Okay. Motion on the bill as amended by the 2 sets of amendments.
So moved.
So
Second.
moved and seconded. On the bill. All those in favor say aye.
But there's a
Aye.
couple of hands up from the Board of Physicians and Delegate Riley.
Okay. Delegate Riley first.
Thank you, Mr. Chair. So on my notes, when we were discussing this bill, we were talking about having an amendment to reduce the fiscal note. Has that, it didn't sound like any of those amendments would address that.
I don't believe so, but I'll defer to the board who's here.
Okay, thank you.
Good afternoon, Chairman. This is Michael Tran with the Board of Physicians. From our understanding, I know that Lindsay hasn't gotten those amendments out yet, but we do not believe any of the amendments are going to be lowering the fiscal note. The board conducted the work group over the interim, and during that time, we did have a fund balance that could cover this, but since then with the BRFA, our fund balance would be reduced by 1.5 million. So we do have slight concerns with the fiscal impact of this bill. But with the amendment, it should not change the fiscal note.
Sponsor, do you want us to move forward with the understanding that it has to be held because of the fiscal note, or would you rather resolve the fiscal note issue first?
I'm sorry, Chairman, can you repeat that? I think I lost.
I guess my question was to the sponsor of the bill, Delegate Cullison.
No,
Oh.
the sponsor of the bill is Delegate Hill. She's not
Oh,
here.
Delegate Hill, sorry,
Right.
sorry.
She's not here.
Well, let's put it on hold then for now.
Yep.
We may resume when Delegate Hill shows up. Okay. Now back to House Bill 838. Health Occupations License Direct Entry Midwives Revisions. Lindsay, Delegate Cullison's bill.
Sorry, this bill specifies that except for specified transfers or consultations, the practice of direct entry midwifery is independent and does not require oversight by another healthcare practitioner. The scope of practice direct entry midwifery and the medical conditions under which a licensed direct entry midwife must consult or transfer the care of a patient are altered. The bill repeals a reporting requirement, alters requirements for specified written plans and procedures for hospital transfer, clarifies the actions the State Board of Nursing may take if an applicant to practice direct entry midwifery or a licensed direct entry midwife violates the grounds for discipline, extends the termination dates for the portions of the health occupations article which govern direct entry midwives by 5 years and makes stylistic and conforming changes. The amendments that I circulated earlier retain that the practice of direct entry midwifery includes notifying a pediatric healthcare practitioner within 24 hours after delivery, strikes language that referenced required transfers and consultation in relation to the independent practice of direct entry midwifery, alters the list of listed conditions requiring transfer, consult, and immediate emergency transfer by striking from the list of conditions requiring transfer to a healthcare practitioner, RH sensitization with positive antibody, I'm gonna mess all these up, sorry, antibody titer, and restores severe anemia, and clarifies they must be unresponsive to treatment based on blood tests performed when the patient is 36 weeks pregnant, restores significant fetal congenital anomaly, but requires that it must directly impact the birthing process or require immediate emergency care. Clarifies that consult for active genital herpes lesions is only except where transfer is required. Requires immediate emergency transfer to a hospital if congenital anomalies are significant rather than life-threatening and require immediate emergency care. Restores the requirement that a licensed direct entry midwife plan identify the pediatric healthcare practitioner who will be notified after delivery to receive transfer of care of the newborn rather than receiving the records of the newborn. Requires the licensed direct entry midwife accompany the patient to the hospital only if it's determined to be appropriate by the midwife and the receiving healthcare provider, and establishes that licensed direct entry midwives will be subject to reporting requirements that are developed by the board in consultation with the advisory committee and other stakeholders.
Any questions about the bill and the amendments?
Mr. Speaker, if I could speak to the bill and the amendments before we take
Sure.
action. So in general, first of all, I want to say thank you to the Maryland Hospital Association and the Board of Nursing and to our midwives who have really worked very hard to try to get to consensus on these amendments. I mean, these groups of people have spent a great deal of time on these amendments. And I want to put it in the context of 10 years ago, when we licensed midwives, we were doing something completely new and different. And we made the statute extremely prescriptive about the practice of midwifery, more explicit than any other profession. So, and we did that out of an abundance of caution. We now have 10 years of experience in Maryland with our midwives, and we've seen great success with them. And we've seen, high rates of positive outcomes. So, so in addition to that, we just passed a bill on third reader in the House, and I believe it will sail through in the Senate, that puts midwives, that defines midwives who are who are covered by supervised by the Board of Nursing in the same disciplinary category as all the other categories for that board. So if what I believe is going to happen, that bill passes and the board will have, it's always had authority, but now its disciplinary authority will be defined. So in that context, I would like for us to speak to some of the disagreements in the amendments that continue. And I am hoping that we can get to agreement. I would love to get to agreement today because I think that we're close. But in the last round of amendments, which you see in the reprint, the Board of Nursing is still struggling with a couple of pieces. And if, with your indulgence, Mr. Chair, may I go through them?
Go ahead.
Thank you. So the first is the reticence to state explicitly that licensed direct entry midwives are practicing independently. And the rationale from the board is this is already common practice, so it doesn't need to be in the bill. I'm going to suggest from what I've heard from midwives is that there is sometimes confusion with the physicians with which they consult and work and collaborate around their independent status. So having it in statute would be beneficial to them and does not change the practice at all. So we'd like to retain that language, explicitly saying that there is there is independence. There was a lot of discussion around the exclusion of the original proposed exclusion of immediate transfer based on severe anemia. I learned more about blood levels in that discussion than I ever thought possible. I think, we were not able to come to agreement on this, even though I learned that midwives actually do regular blood testing through the course of prenatal care. So they are constantly monitoring the appropriate blood levels for anemia. Anytime that there is that the person goes below 10 of the units, and don't care what the units are, but 10 of the units, because that's the standard, that person would need to be treated for the anemia. Sometimes it can be treated with simple iron pills. Sometimes it needs to be an infusion of iron. If it needs to be an infusion of iron, the midwife already alerts the patient and says, or the mom, and says, go to the physician to get an infusion, either of blood or iron. So that's already happening. But under the current law, they have to then give up the patient, even though the patient may respond immediately to the treatment and then want to proceed with the midwife. So the reason we put 36 weeks in here is because that's the point, we're getting close to delivery. And if the anemia is severe at that point, there could easily be an immediate transfer. On the congenital fetal anomaly, I've learned that the most common fetal anomalies that both midwives and OBGYNs, and I will say, midwives have been around a lot longer than OBGYNs, that is some sort of physical anomaly, like an extra digit or a cleft lip, which are not life-threatening, which are not putting the baby in any kind of serious danger. And the transfer process does not have to happen immediately if it's not putting the baby into a need for emergency care. The Board of Nursing wants to retain any congenital anomaly would result in an immediate transfer. And the last piece, one piece that we are willing to accept is to say, we had removed the annual reporting requirements in the bill. After a lot of discussion, we thought it would be useful to perhaps in the bill require DMAC, which is the committee that the diverse committee that looks at the practice in the state, to develop an appropriate, maintain the current reporting, but charge them with developing a more practical reporting process, over the air. So that part we're agreeing with. The last part that we're still struggling with is what kinds of documents and how should the midwife connect with the receiving entity around the kinds of medical records that are needed. Under current law, the midwife must go to the hospital if the mom is transferred to the hospital. And what we've heard is that's not always practicable. And if you consider what happens in practice, the midwife is connecting with the EMT and then with the receiving hospital, at least always on the phone if they don't actually go. And I actually feel like some of this could be dealt with in regs and not in statute. And the statute should refer to how do we develop the best communication process between when there is a transfer, as opposed to being very specific in the language. So those are the issues that we have not agreed on. And I'm happy to hear from the Board of Nursing about, whether we can move on some of these things.
Thank you very much, Delegate Collison, for that summary. Who wishes to speak in response? Mitzi Fishman.
Yes, hi everyone. Thank you, Madam Vice Chair, and good afternoon, members of the subcommittee. As far as addressing the specific points and trying to come to a consensus today, I don't believe we're able to do that, and Rhonda can confirm, but I will say, and I apologize.
Why are you unable to do that? That's the purpose of the meeting.
So I'm not from what I'm told, I'm not authorized to make decisions without consulting the board's legislative committee. I believe Rhonda can expand on that a little bit more.
Yes, good afternoon, everyone. Thank you, Mr. Chair and Madam Vice Chair. So as board staff, we can't come to make the consensus. We basically take the points back to the board members in the legislative committee, and they make the determination on how they want to proceed and what their position is. I believe the board member that we had online had to jump off. So right now is Ms. Fishman and myself, but overall, we can say that the board is still struggling with the safety and the public protection aspect of this, and it doesn't believe that the practical elements that this bill is aimed at addressing supersedes or trumps their concerns with public safety. Certainly, the board is open to working with the group, but at this time, the board is still having a problem with coming to an agreement on a lot of these amendments, or the amendments that Madam Vice Chair described. And I'm sorry, go ahead.
Have there been discussions about these specific amendments, Madam Vice Chair?
Yes, there have been. And Mr. Chair, I would ask Rhonda to help me understand where the safety concerns are, because we have not seen issues in the 10 years that midwives have been operating in a licensed as licensed professionals in Maryland.
So the unfortunate thing is I can't give specific site-specific cases, but the board, we are, in charge of overseeing cases. We receive complaints, we address them of specific instances. And while we know that it's been 10 years of practice, I think the board feels like we're not quite there yet when it comes to addressing a lot of the safety concerns. And I know specifically the board's responses to the amendments were provided for each point. But overall, the issue is just, we just don't feel like, the board members just don't feel like we're there yet. They are more concerned with the public protection than the practicality of it. And I know that particularly with regards to, and I can go through, if I may, some of the responses to to what you went over, Madam Vice Chair, if that's okay.
Mhm.
With regard to the independent practice, again, the board does feel that it's unnecessary, and that, basically the group, it would really be beneficial if the group worked with these on building professional relationships with physicians so they better understand the role of the direct entry midwives, versus just putting this explicit language in a bill or in law that is in no other statute. And the language is somewhat broad and misleading, and it doesn't provide clarity, but rather allows the reader to think the role of the licensed direct entry midwife is broader than intended. With regard to the anemia, transferring a patient with severe anemia that is unresponsive to treatment based on blood tests performed when a patient is 36 weeks pregnant. What the board identified is that at 36 weeks, growth and development of the baby can be impacted already. Also, early delivery can be a complication of severe anemia, and at 36 weeks is likely past the point of being able to prevent that. 36 weeks doesn't address the concern about how providers define unresponsiveness to treatment. IV iron and transfusion should be monitored by a physician or advanced practitioner with the appropriate training. And then as far as transferring a patient with significant fetal congenital anomaly, that directly impacts the birthing process or requires immediate emergency care. The committee felt that managing congenital anomalies should still be left to the appropriate providers with the advanced training, and request to maintain it in current law. And as far as the reporting requirement, I know that we did talk about, working to try to update the requirements, but currently and right now we were just concerned that the information that the group provides in their annual report isn't available to the public anywhere else. And even when looking at the Vital Statistic Administration records, it doesn't separate out planned home births from all other births. So those were some of the concerns related to that. And thank you for your time and this opportunity.
Ms. Brody?
I actually raised my hand before. I was going to probably ask the same question as Delegate Cullison of what were the specific, public safety concerns. Because the good news is, my name is Tova Brody, by the way. I'm a certified professional midwife and licensed direct entry midwife. Our priority is also public safety. So I'm glad that we're both on the same page and have the same end goal. And we appreciate your guys' time on this. But yeah, my question was going to be specifically, what about it? I don't know if this is the time and place to address point by point, or if we, because I feel like we reviewed this a couple of days ago in our subcommittee meeting with all the stakeholders and went through. Delegate Cullison, is this something I should be responding to point by point here?
Not point by point. I think I covered it pretty well, but if there are other things in terms of what that you'd like to respond to with that Rhonda said, that would be fine.
In response to kind of the Board of Nursing's concern, just on a couple of things, specifically with regard to the anemia, I feel like this is coming to a misunderstanding almost, that we are practitioners who diagnose and provide treatment for this. And we truly do the exact same standard of care that an obstetrician would do when it comes to treating prenatal anemia. And I would even say maybe we go further because we have the level of continuity of care. We actually do our own lab draws. We are one provider looking at a full picture and counseling with nutrition and supplementation. And when you say that, if it gets to iron infusion, this should be, overseen by a physician, like we're referring to a hematologist for that. So that would be overseen by a physician. I understand that 36 weeks is a pretty late threshold.
A bottle of bourbon at the parlay. John,
Whoever is speaking, please mute yourself.
Yeah, so I just wanted to clarify that point. Like at 36 weeks, this is not a threshold where if we've neglected this person and we're leaving them to, be insanely severely iron deficient, and then we're abandoning care at a time when they're, term and at risk. That means that care had been managed until then. And if as a midwife, they have a patient that has not been responding earlier than that, it would have already been referred out. That's particular number one. And I just wanted to speak to, I sit on the Direct Entry Midwifery Advisory Committee at the Board of Nursing for the past couple of years. Like, we collect those data collect entry forms. The data collection process, I do it as a midwife, and I compile the data on behalf of the committee. They're really, really complicated. And again, I think they were put together to be as thorough and conservative as possible. But I think many midwives have a hard time completing them, and we have a hard time compiling the data, which just makes it not good data. And I would hope that you have gone through it, and I suggest anyone who has not to actually go through the current forms as they are. They're written really, there's a lot of challenges in how they're written, and a lot of numbers could be reported multiple times. So I just feel like if it's not giving us clear data, and we are, again, the vital records data is streamlined. It's telling us if baby was born at home, if it was transferred within 24 hours, a lot of really great points, and it's much more streamlined and organized. I just wanted to encourage anyone, with this data point, to really kind of put the two collection forms side by side. And I think that if we want to add maybe to the vital record some specific transfer, home birth transfer specific data language, maybe. But right now, the current form as it is really not user friendly on the provider filling out form or on the board collection form. And I think even as a consumer, to go on the website and read the data, it's overwhelming. Myself, before I was a midwife, it's overwhelming. So the one more thing also on significant anomalies, I know that's a really tough point. I think it feels to the board like we're handing over high-risk patients to, a low-risk community birth setting. That's absolutely not the case. Again, I encourage everyone to think about the fact that if a baby has extra digits, it's, seen on an ultrasound, or if it comes up at the birth process, that is not in any way impacting the birthing process, the postpartum process, the immediate care for the baby. And now this triggers an emergency transfer of care or a prenatal transfer of care because there is an anomaly. So things in maternal health care are really broad spectrum, can get very situational dependent. And at some point, I think it would be helpful to recognize the midwives as practitioners, and also to recognize the informed consent that patients are able to have with regard to their, practitioner choice and birth setting. Thank you for your time.
Thank you. I'm going to hear from Caitlin McDonough.
Yeah, and I think Tova laid out most of it, but one thing I just would remind the committee and potentially the board as well, nothing in this Practice Act would preclude a patient from also seeking care from a physician, whether it be a specialty physician for any of these conditions. But what we struggle with is the idea that they now have to transfer maternal health providers solely because they may be seeing another physician to deal with their anemia or deal with a congenital anomaly or something like that. And that becomes, we would raise that as a public or a patient safety issue as well, because what we see is now this patient no longer has, because they are experiencing another condition that they can absolutely seek treatment for, they now have to change maternal health practitioners mid-pregnancy. That may take time. And, given the nature of the patient seeking this home birth care, they may also then choose to go to an unlicensed practitioner or out of state or things like that, which are issues we've grappled with in the past. We think maintaining that continuity of care for the maternal health practitioner while still allowing patients to see physicians or specialists or whatever else they need to do for some of their underlying conditions, actually provides an abundance of safety for those patients. So kind of building on what Tova said, but I just want to be clear. This doesn't say just because you see a hematologist, you can't see a midwife or vice versa. Just because you see a midwife doesn't mean you can't see a hematologist or, a heart, a cardiologist for a heart condition or anything else.
Ms. Crone?
I didn't mean to do that.
Thank you, Mr. Chair. My name is Christine Crone on behalf of the Maryland section of the American College of Obstetricians and Gynecologists. And I just want to first say thank you to Caitlin. She and I and the other stakeholders that have been mentioned have been involved in this process since December. Unfortunately, I wasn't included in this week's meeting, but I wanted to touch on something that Rhonda from the Board of Nursing said about anemia. And I appreciate Caitlin working through this amendment with us. I would like to suggest that the language would say is unresponsive to treatment based on blood test performed beginning with 36 weeks of pregnancy, not just at 36 weeks.
Like keep doing them all the way through the end. I'm sorry.
Yeah, the way the language is wording right now, it seems like just at 36 weeks, but we want to make sure the whole third trimester is captured.
And I think that sounds fine. I think at that point, though, if we're getting that close to pregnancy and they're still anemic, we would transfer care. So then the obstetrician would then take over. But I don't think it would preclude continuing blood testing. I assume that would be happening.
Okay. Thank you.
But makes sense. Yes.
Nikki Williams.
Hi, my name is Nikki Williams. I'm also a certified professional midwife. I wanted to address the point about independent practice. Up until 2015, certified nurse midwives were required to have a supervising physician. And in 2015, that requirement was lifted. In their COMAR 10.27.05.06, in their scope of practice, it specifically says, a certified nurse midwife who meets the requirements of Regulation .02 of this chapter may perform the following functions. 1, independent management of clients appropriate to the skill and educational preparation of the certified nurse midwife and the nurse midwife's clinical practice guidelines. And then it goes on. Certified nurse midwives are functionally the same as certified professional midwives, except for they have an expanded scope. I'm just really wondering, why is it a problem for us to have the specific wording independent management of clients when certified nurse midwives have that? I've run into this problem several times when Care First actually does not sometimes want to cover the lab work that I order for my clients because I do not have an overseeing supervising physician. So it's very helpful to have something in law that says that I am an independent practitioner. And I think that's kind of where we are aiming for this. It's not necessarily so that we can get away with doing more. It's so that we can represent ourselves to the wider medical system that still doesn't recognize us. Thank you.
Delegate Cullison.
Thank you, Mr. Chair. Thank you for your incredible indulgence, and thank you to the subcommittee for this.
It's not indulgence, we're trying to pass a bill.
Right. I want to
Solve a
point out
problem.
that, sorry. I'd like to point out that Christine Krohn represents the obstetricians and gynecologists, and she just associated herself with the amendment that the latest amendment relative to anemia. And I know that MHA, and Natasha, you tell me if I'm wrong, that MHA is comfortable with the amendments as we are going forward. So I'm going to ask, Mr. Chair, that we, if again, with your indulgence, that we hold this until tomorrow. And if the board has language that can recommend language that will make improvements that they can live with, we'll accept them. But other than that, Mr. Chair, I'd like to move forward. So
I understand that, very much so. So does the board understand that you've got until tomorrow morning to get amendments to the sponsor?
Yes, Mr. Chair. Yes, Mr. Chair. And we'll make sure that we get this urgently to the committee. Thank you.
Good.
Thank you both.
Okay.
Thank you, Mr. Chair.
Thank you. I hope, Delegate, that was helpful.
It was very helpful. I sincerely appreciate your time and
Certainly.
the committee's time.
That's what we're here for. Council, are there any remaining bills?
I see that Delegate Hill has joined.
Oh, okay,
I
right.
think at least a couple of people are still here from the Board of Physicians. I don't know if there's interest in returning to that bill, if that's okay.
Well, let's try to resolve 1199. physicians licensing internationally trained physicians. So there is a high fiscal, is there agreement on the amendments? There is not, correct? Or Delegate Hill, can you fill us in?
I'm sorry, Mr. Chair, what were you asking me?
Can you fill us in on the status of the amendments?
Yeah, I think we're good. I think the amendments that I've sent around are consensus amendment. We had some requests from the faculty physicians at University of Maryland and physicians at Hopkins, which the work group just did not feel gets to the point of this bill. And I think if we move forward after they were worrying about physicians who they may be recruiting in, and that's not the purpose of this bill. And because this is such a new idea, I would prefer that we see how this works first with the physicians who are here, who have a nexus with Maryland, have lived here for at least a year. And we did take one of their recommendations, which is to change the 5-year practicing in another country to 5 of the last 7. But they wanted us to remove the 1-year nexus. And I think they have an alternative pathway that already exists that they use to recruit people. Unfortunately, it does require still going through a residency program. But again, I think we do better going with what the consensus was with the work group. And then once this gets up and working in 2027 or 2028, if there's a reason to say this works really well, and we would like to expand this pathway, then we can do that. Or if we need to, so that's what I would say.
So there is agreement on on language?
Yes.
What about the fiscal note? Can you speak to that, or we still have to resolve that?
I have to I'm sorry,
It's okay.
For some reason, it didn't even occur to me. I didn't realize until shortly that I was gonna be coming today. But the fiscal note, thank you. Oh, it's special funded, right? So because the board is a special funded board, they can charge a fee for this licensure to cover.
Okay. We'll double check that with the chair, whether that's, do they?
Yeah,
do
and
they
then
have
if you
that
read the
authority?
fiscal,
They don't
if you read
just-
the fiscal note, that's where what it actually says.
And they
So
have that
the
authority.
board fees, the board does not get fees except it runs off the fees of the licensees. So all of the things that the board does are funded by licensee fees.
Okay.
And in fact, the licensee
Lindsay,
fees
have you had an
also
opportunity-
fund the scholarship fund or the grant fund. So
So you have an agreement with the physicians?
I'm sorry, I have agreement with
well, not just the relevant
MedChi,
parties.
the Board of Physicians, the other people participated in the work group, which, I mean, I can get that list for you of who all participated in the work group. But we've got Mr. Tran can speak to that, and Mr. Floyd has his hand up too.
Okay. Mr. Floyd was first, please.
Thank you, Mr. Chair. Thank you, Mr. Chair. Good afternoon, everyone. Brandon Floyd with Johns Hopkins. Just had a quick question. Wanted to confirm which physician, Delegate Hill, you have been working with from Johns Hopkins for our records.
I have no idea who. I don't know if anybody from Hopkins was there. Mr. Tran, maybe the invitations came from the board, and I know when we met with University of Maryland physicians, I guess 10 days ago now, and they said that they had not participated in the work group. The board said you had received an invitation, and it might have gone to University Maryland writ large, and they had not participated, and it might have been the same thing with you all. So
okay,
I didn't say that. I didn't say that Hopkins was there, but Mr. Tran can speak to who the participants were with the work group.
Okay, great. Thank you, Delegate Hill.
Yes, so when it comes to Johns Hopkins, I can connect offline and get the names if we have them for who attended the work group, and get back to you on that. And then regards to Delegate Hill's comments regarding the amendments, Lindsay just sent those out and we got them and the board has reviewed them and we're okay with them. And then in regards to the fiscal note, the board is in support of the bill. However, during the work group, there was a fund balance and could cover it, but now with the BRFA, we are getting $1.5 million taken away. And then with everything going on and just the amount of money it's going to take to contract out certain services that would address the bill, we don't know how much money that's going to be. So we aren't sure if we could totally cover it, but again, we are still supporting the bill, and with the expected date of 2027, I think we should be okay.
Okay, is there a motion? Is there a motion on the amendments?
So moved.
Second.
Okay, is there a discussion on the amendments? All those in favor of the amendments, please say aye.
Aye.
Anyone opposed to the amendments? They are adopted. Is there a motion on the bill as amended?
So move.
Second.
Moved and seconded. All those in favor of the bill as amended? Say aye.
Aye.
Anyone opposed? Okay. Council. Is that? Oh, no. Do we have any?
That's all I've
1298?
got right now.
Pardon?
That was Lisa's.
Okay, so we did discuss that. It's a hold. Any other bills of yours, Lindsay?
No, I've got and am working on the amendments for House Bill 776. Hypothetically, you guys could return to that if you felt comfortable with it. But I don't have them finished yet.
Okay.
But we will meet
We will meet again, yes. I'm sorry, what were you going to say?
I just said we will meet tomorrow, so they'll be
Okay.
ready for that meeting for sure.
Okay. There being no further business before the
Delegate Hill's got
Delegate Hill.
Yes, Delegate
I'm
Hill.
sorry, Mr. Chair, I didn't hear. Did you say that 1199 is on hold?
No, we voted on it.
Oh, okay. All right. Thank you. I just wanted to be clear. Okay. Thank you.
Certainly.
Thank you so much.
Okay. We are adjourned to return.